Hello, my name is Katie Armato. This presentation is my research-based portfolio on behavior interventions for food selectivity in autism spectrum disorder. I'll summarize the literature, discuss home, school, and community challenges, review essential skills and effective teaching strategies, and highlight key considerations for practitioners. This presentation is derived from a combination of work from this semester, including but not limited to a literature review, a behavior intervention plan contrived from the information in the literature review, and a previous presentation that aimed to share similar information but for a different audience of education-based support staff for the students that demonstrated food selectivity. My goal for this presentation is that you walk away with some information on current research and ways you may continue to develop research in this area, or strategies you may use with your own clients that demonstrate food selectivity. These studies provided evidence for the efficacy of individualized, reinforcement-based approaches. The focus of this literature review is on peer-reviewed studies published between 2014 and 2023 that utilized experimental methodology and applied behavior analysis principles to address food selectivity in children with autism spectrum disorder. The inclusion criteria required participants to be under 18 years old, with intervention components based on behavior analytic strategies. Additionally, the dependent variables had to be clearly defined as food acceptance, consumption, or the reduction of inappropriate mealtime behaviors. Out of 300 initial articles reviewed, only 6 met all the methodological criteria. Gast et al. 2020 used a multi-component intervention with prompting and reinforcement in a natural preschool mealtime setting. Gover et al. 2023 used assent-based child-led interventions using shaping and differential reinforcement. Burrell et al. Used the meal plan, a structured caregiver-mediated behavioral protocol. O'Connor et al. 2020 used video modeling combined with reinforcement to increase food acceptance. Clark et al. 2020 used a structured meal procedure with parent training through video and in vivo coaching. Peterson et al. 2019 used a randomized controlled trial of multi-component intervention, including escape extinction. These studies provided evidence for the effectiveness of individualized, reinforcement-based approaches. However, they also highlighted gaps in generalization, long-term maintenance of outcomes, and operational consistency. Complex reinforcement contingencies often maintain food selectivity in children with autism spectrum disorder. These may involve both negative reinforcement, such as escape from aversive sensory stimuli, or difficult motor responses, and positive reinforcement, such as access to highly preferred foods, or attention for mealtime avoidance behaviors. For families, these contingencies can result in persistent, maladaptive feeding repertoires, where avoidance of non-preferred foods is reinforced repeatedly across settings. Over time, the child's food repertoire becomes increasingly narrow, and attempts to expand it can evoke high rates of problem behavior. Nutritional deficits are common, with selective eaters often consuming fewer fruits, vegetables, and proteins, which can contribute to secondary health concerns. The emotional toll on families is significant. Meals become high-stress events, with parents experiencing anticipatory anxiety about potential refusals or meltdowns. In many cases, families adapt by only serving accepted foods, inadvertently strengthening the avoidance response or extinction of exposure opportunities. Social limitations can further restrict naturally occurring reinforcement opportunities. Families may avoid restaurants, holiday meals, or school events involving food to prevent public incidents. This reduces the child's contact with varied mealtime stimuli and hinders the generalization of eating skills. Over time, these avoidance patterns can contribute to behavioral rigidity that is resistant to change, making early intervention critical to prevent the behavior from developing long histories of reinforcement. When implementing feeding interventions in school or community settings, behavior analysts must consider environmental variables that can alter motivation for eating and affect the likelihood of target behaviors. In school lunchrooms, high noise levels, unpredictable peer interactions, and time constraints can function as motivating operations that decrease the reinforcing value of food acceptance and increase escape-maintained behavior. Short meal periods, often 20 minutes or less, limit opportunities for systematic prompting and reinforcement, making it difficult to conduct enough trials for shaping or desensitization. Social dynamics can also be complex. Peers may provide attention for refusals, or a student may avoid eating to escape social demands, both of which can inadvertently reinforce these behaviors targeted for reduction. In addition, students with restrictive diets may be excluded from activities such as cooking projects or community-based instruction, limiting their access to natural reinforcement for varied eating. In community settings such as restaurants or birthday parties, novel foods are often introduced in contexts with low control over antecedent stimuli and limited access to preferred reinforcers, making generalization more difficult. These environments may also lack trained staff capable of delivering consistent prompts and reinforcement, which can lead to poor treatment integrity and potential regression. These challenges highlight the need for interventions that are portable, feasible, and designed with built-in generalization strategies, such as caregiver training, preference assessments adaptable to multiple contexts, and reinforcement plans that remain effective even in busy or unpredictable environments. Essential skills for intervention. Skills requiring systematic instruction include food exploration behaviors. We start by helping learners simply tolerate non-preferred foods in view. From there, we work up to touching or smelling the foods. These small steps help pair the food with neutral or positive experiences. Gradual taste acceptance. Once touching and smelling are comfortable, we move to contact like kissing or licking. Then, we shape towards small tastes or partial bites before full bites and swallowing. Each step keeps the effort low while building success and momentum. Self-regulation during meals is also another component. We teach tools to stay calm and engaged. We can teach a student to request a short break or use a break by using a break card instead of leaving the table unexpectedly. Additionally, social mealtime behaviors. We embed opportunities to sit with peers, share conversations, and follow mealtime routines so eating feels more natural and socially rewarding. Communication of preferences. Learners practice requesting foods they want, saying no appropriately, and asking for alternatives. This replaces refusal or escape behaviors with functional communication. Coping strategies. When a texture or smell is tough, we give learners options, taking a sip of water, using different utensils, or gradually working up to more challenging foods. Independence in food choices. Over time, and with increases in food repertoire, we fade adult support so learners can choose their own foods, decide portions, and control the order of eating, skills that make progress stick outside of therapy, making them more easy to generalize. Evidence-based teaching strategies. The literature identifies multiple behavior analytic strategies that demonstrate efficacy in reducing food selectivity. Differential reinforcement of successive approximations, or using differential reinforcement. Reinforcing incremental, systematic steps towards a terminal goal. Studies show shaping increases acceptance without relying solely on escape extinction. Systematic desensitization and stimulus fading. Gradually increasing exposure to non-preferred foods while pairing with reinforcement to reduce conditioned aversiveness. Video modeling and visual supports. Presenting visual exemplars of peers or models engaging in target feeding behaviors, which can prime imitative responses and establish a discriminative stimulus for reinforcement availability for the learners. Parent training protocols. utilizing behavior skills training to teach caregivers how to implement feeding procedures with fidelity, ensuring maintenance outside of clinical sessions, choice-based interventions, embedding opportunities for the learner to choose foods or interaction levels, which can serve as an abolishing operation for escape and increase assent. Research shows that multi-component interventions that integrate several of these strategies tend to produce more robust and generalized outcomes than single-component approaches. Implementation effectiveness. Success rates across interventions. Across the reviewed literature, most participants demonstrated increases in independent bite acceptance and decreases in inappropriate mealtime behavior. The highest effect sizes were associated with multi-component treatment packages, incorporating differential reinforcement, shaping, and caregiver-mediated generalization. Some factors influencing outcomes. Treatment effects were moderated by learner-specific variables, including a learner's sensory profile, their history with non-preferred stimuli or foods, and prerequisite repertoires, such as generalized imitation for video modeling being used. Reinforcer efficacy was a critical variable. Without potent reinforcers, shaping hierarchies often fail to produce terminal responses. Treatment duration requirements. Response acquisition rates varied, with some participants achieving mastery within a few sessions and others requiring extended intervention due to high baseline avoidance or multiple response topographies targeted concurrently during the treatment. Resources needed. Interventions with high clinician-to-learner ratios, reliance on specialized or controlled clinical conditions demonstrated efficacy, but reduced generality and social validity when implemented in natural settings without those resources, making it difficult to replicate. Staff training requirements. High procedural fidelity across therapists, caregivers, and settings was correlated with greater maintenance and generalization. Effective training protocols included behavior skills training, in vivo feedback, and ongoing performance monitoring to maintain treatment integrity above 90%. Family involvement impact. Caregiver participation functions as a mediator for generalization. Within the moment coaching, varied setting implementation, and natural reinforcement delivery, producing more durable stimulus-response relations across environments. Long-term maintenance data. The most behavior change occurred when generalization contingencies were embedded from the onset of the treatment, including multiple exemplar training, varied establishing operations, and reinforcement by naturally occurring reinforcers. Maintenance probes beyond intervention phases were limited in the literature, indicating a need for a longitudinal follow-up. Critical understanding points. A key takeaway for practitioners from the literature. Individualization is incredibly important. The studies made it clear. No two participants responded the same way. For example, in Gast's work, some kids made progress just with shaping and reinforcement, while others needed more intensive strategies like escape extension. The best results came from tailoring every step, goals, prompts, reinforcement, to that specific child's preferences, skills, and learning history. Start with medical clearance. Before we jump into the behavior plans, we need to make sure nothing medical is driving the problem. Research shows that issues like GI discomfort, swallowing difficulties, or nutritional gaps are common in this population. Collaborating with doctors, dietitians, and speech therapists helps us target the real barriers instead of treating the wrong thing. Sensory processing can make or break success. Many kids with autism are highly sensitive to texture, taste, temperature, smell. Studies like Gast showed that letting kids touch first or smell food first before tasting can build trust and acceptance. Gover's research added that when kids had choice and their sensory needs are respected, the problem behaviors decreased. Family training is essential. Interventions work best when they leave the clinic. In Burrell's meal plan study and Clark's parent training work, caregiver coaching was the key to maintaining progress. Without it, the participants often slid back into old patterns once formal sessions ended. Peterson's work showed that combining skill building with reducing avoidance behaviors got better. There were longer lasting results focusing on just one area. That means teaching bite acceptance or chewing while also addressing escape, maintain, refusal in a step-by-step way. We're most successful. Keep a positive, non-aversive reinforcement heavy strategies like those in Gover's and O'Connor studies were not only effective, but also rated higher by families. When children and families feel respected and have choices, they're more likely to stick with the program. Let the data guide you. The most successful research collected data every step of the way. Things like number of bites, mouth clean, or problem behaviors. This allowed them to tweak reinforcement schedules or adjust goals as soon as progress stalled, keeping momentum going. Essential knowledge for practitioners. Practitioners implementing feeding intervention should be proficient in several key areas. Assessment protocols. Conducting thorough functional analyses of mealtime behaviors to identify maintaining variables, differentiating between escape maintain behaviors due to sensory sensitivities and those tied to task demands or other factors. Treatment selection criteria. Design individualized function-based interventions, incorporating evidence-based strategies, and selecting methods that align with the child's preferences, needs, and assent. Progress monitoring systems. Use operational definitions and reliable data collection systems to track food acceptance, consumption, and inappropriate mealtime behaviors, adjusting criteria as mastery is achieved. Modification strategies. Adjust reinforcement schedules from dense to intermittent while avoiding ratio strain, and alter intervention components in response to changes in behavior, refusal, or skill acquisition plateauing. Crisis intervention plans. Develop safety-focused protocols for managing severe problem behaviors during feeding, ensuring responses preserve the individual's dignity. Coordination with medical professionals. Collaborate with speech pathologists, occupational therapists, and dietitians to address oral motor skills, sensory needs, and nutritional adequacy as part of an interdisciplinary approach. Family support systems. Provide structured caregiver training, such as behavior skills training or in vivo coaching, to promote generalization, maintenance, and prevention of regression after formal intervention ends. Here's some examples of the behavior plan that was within my portfolio. This slide summarizes recommendations derived from the literature and my portfolio work. Target behaviors included tolerating food proximity without avoidance and engaging in a systematic hierarchy of interaction steps towards full food consumption. Teaching structure involves embedding 2 short intervention sessions into natural meal times with 5 discrete trials, and mastery defined as 100% independent correct responses for 3 consecutive sessions. Core strategies included differential reinforcement of successive approximations, least to most prompting to minimize frustration, ongoing preface assessments to maintain reinforcer potency, generalization being planned by systematically varying the settings, discriminative stimuli, people, and materials, and ensuring parent-led practices for maintenance. Ethical considerations emphasize assent and learner choice, ensuring that any use of more intrusive procedures like escape extinction is justified, monitored, and introduced only when less intrusive methods are insufficient and not demonstrating behavioral change. The ethical and social validity considerations are essential for BCBA level feeding interventions and also need to be thoroughly thought of when conducting research or creating a plan. The BACB Ethic Code outlines our responsibility to ensure client dignity, obtain informed consent, and avoid harmful procedures. Assent is a critical factor. If a learner shows signs of distress, the procedure should be paused and modified. Practitioners must balance effectiveness with intrusiveness, always beginning with the least restrictive methods and reserving more intrusive approaches for situations where all other options have been exhausted. Cultural responsiveness means incorporating and respecting the family's dietary traditions, preferences, and values within the intervention plan. Finally, social validity assessments ensure that the goals, procedures, and outcomes are meaningful and acceptable to both the client and caregiver, which directly supports generalization and long-term maintenance. Here's a list of the references. I hope that this helps and goes back to what my key takeaways that I hope that you're able to take some of this information on the current research and either apply it to developing your own research or implement some strategies that you may use with your own clients that are demonstrating food selectivity. Thank you so much for your time.